Thanks everybody for coming. You are here at MiHIN's The Download. This is a monthly, mostly webinar diving into the intersection of healthcare and technology. So we have two sort of offerings, public offerings. One is The Download and one is Bits and Bytes. The Download has been sort of our attempt to handle these bigger topics. And the bigger topics are handled in a way that we really focus on the why and the who. And we have another webinar called the Bits and Bytes. And Bits and Bytes is really focused on more about the how and the what. It's more technical. Usually we have more of our technical staff on it to support. So today is the download. And I am Joanne Brownstein-Jarvie. I am the Senior Director of Customer Experience at MiHIN, and I appreciate you joining. Next slide. A little bit of an overview. You guys, everybody probably already knows, but MiHIN is Michigan's state designated health information exchange. We are a nonprofit. We have a board that is staffed by many representatives from different sectors in the healthcare ecosystem. We are not owned or controlled by any government. We are not owned or controlled by any payer. We are not owned or controlled by any health system. We sit in the middle and act as a neutral third party convener to help share vital information. Next slide. And we do this at scale. So we are dealing with many participants, many different care entities, exchanging data for many different people. And we really are sitting in the middle and in between and transforming and normalizing and exchanging data on a shared ecosystem, on a shared digital infrastructure that our ecosystem has invested in over many years. And it is our privilege to do so. Today, we are going to be focusing on the other F word, migration. We are embracing progress here at MiHIN, and we have embarked on a full technology platform migration. And I'm going to go into the whys of it today and who it benefits. Thanks, Kaylee. So I'm going to turn off my camera. You guys are going to miss me, I know, but you'll still be able to. So MiHIN has been working tirelessly on a significant initiative that we believe will greatly enhance our technical capabilities to support electronic exchange of clinical, non-clinical, administrative, and public health data to enhance care delivery, bolster population health, and expand public health reporting. Our integrated technology platform is designed to make data available, useful, and interpretable to all providers of care and support in a variety of different methods to help get as much actionable information out to the community as possible. The goal is always to make critical information as effortless to access as possible, no matter what your system of record. So MiHIN was created, nope, go back. MiHIN was, thanks to the timeline, please, Kaylee. Thanks. MiHIN was created 13 years ago to share patients' electronic health information across hospitals and health systems and providers. And it turns out once you've been around for over a decade, the technology that was then new and innovative is no longer new. It actually picks up the word legacy. About a month before the pandemic, MiHIN completed its corporate affiliation with another Michigan HIE And the market demanded we continue to build on what was working. Over the past decade, health information exchange technology has undergone a remarkable evolution, progressing at an unprecedented pace. Our commitment to Michigan and to our stakeholders and customers is to provide a shared infrastructure that supports the transformation of care, the future of care, the future of public health. And that's why we're here today to discuss a vital step in that journey, a technical migration. So why is this migration necessary? As you all probably know, technology never stands still. Eventually, the day will come when it's too expensive and too labor-intensive, too time-intensive to keep supporting an existing product. Every business decision MiHIN makes is with the aim of generating the most value for its diverse and growing network participants and stakeholders. The decision to re-platform is no different. Just because our initial system was developed with a certain target market and business model in mind doesn't mean that that can't shift. Indeed, when we started, ADTs were not being shared. We started something, we learned, and we iterated on it. Our re-platforming initiative follows the same pattern. Some features just don't make sense to build, despite the fact that someone somewhere may want it. Within a balanced network, what you create for one will impact all others. Our current platform has served us well. I think you can go on to the next slide. Our current platform has served us well, but embracing the latest advancements will allow us to provide you with faster, more secure, and feature-rich experiences. The long and short of this is that we've got to make we've decided to make the slow, steady transition away from some of the environments that we've both built and inherited. We've been running these sort of parallel environments, and we made the tough decision to bring all of these worlds together into, next slide, this integrated technology platform. So MiHIN is working with Smile Digital Health, a leading fast healthcare interoperability resource, health data fabric, and exchange solution provider, to future-proof our modernization investment by building an open standard ecosystem and with cloud-native computing. Along with Smile's robust privacy and security certifications, its scalability allows MiHIN to enhance our solutions. With Smile, we're building an infrastructure to serve up a FHIR repository. Because the world's migrating to FHIR, not using FHIR universally, we're also doing the job of bridging the gap between our legacy way of doing things and this new space. Smile has all the things we're going to need, like CQL, clinical quality language, things like CDS hooks. It's got places for us to take our electronic consent pieces that we've been evolving into and to continue to wrap them up in more of a modern way. Next slide. MiHIN's current environment is limited in its ability to handle the volume and complexity of data that we standardize, normalize, measure for conformance, attribute, and route. Our new platform is designed to run a true integration engine that employs cloud technologies, making it more durable, reliable, and performant. Instead of relying on one off-the-shelf engine, we'll be able to run as many servers necessary to produce like a hive. This will allow us to scale our operations to meet the needs of our growing network. Throughout 2022 and 2023, we identified and resolved challenges that affected the routing and normalization of outbound ADTs to receiving organizations. These are the types of issues that we are addressing in our migration to our new FHIR-based integrated technology platform. Because MiHIN executes more than just one-to-one ADT notification by standardizing, normalizing, measuring conformance, and pushing the data to many members of a patient's care team instead of just, let's say, a PCP, we have hit all the limits on what is becoming our legacy processing platform. Next slide. We are building with all the V's in mind, the volumes of data that we expect to reach unprecedented heights, the velocity of data, how fast that data is coming in, and how critical it is to be exchanged in a timely manner. The variety of data. The ITP, the Integrated Technology Platform, is being built to support many exchanges from many different sources, including all those that we currently work with in our network, and growing to include sources like a pharmacy information exchange, all payers claim database, community information exchange, other referral sources such as public health, and self-generated or patient-generated data. We're also looking at the variability. In addition to the increasing velocities and varieties of data, the data flows are unpredictable, changing often and greatly varying. It's challenging, but it's MiHIN's job to manage this daily, seasonal, and often event-triggered peak data loads. Because data comes from so many different sources, it's difficult to link, match, cleanse, and transform data across systems. This is, we look at this as the veracity of the data. MiHIN connects and correlates relationships, hierarchies, and multiple data linkages. Next slide. The security of our network is our top priority. This new platform incorporates the latest security accreditations and certifications by including federal and state regulations, standards, and frameworks, and incorporating a risk-based approach. Our organization addresses security and data protection challenges through a comprehensive and flexible framework of prescriptive and scalable security controls. Our organization is, maybe go back. Thanks. Our organization is continually under pressure to meet complex compliance and privacy requirements that include technical and process elements such as NIST or ISO. We have been proud to demonstrate to our customers the highest standards for data protection and information security, and plan to continue doing so. Next slide. This migration is designed to improve the operations of our enormous Michigan footprint, to make it better at every level. It presents a unique opportunity for our organization to streamline and optimize our processes and to rebuild our customer experience, how we communicate with, respond to, and innovate with our participants, and how we do that differently. The upgraded platform opens the door to a standard Smart on Fire viewer that can allow participants to look into our clinical data repository. We are doing our absolute best to map all of these source systems into, right now today, into our Fire repository, and make it so that anything that gets mapped to our Fire repository will be available via a Fire API. So with Fire on the front end, you don't have to long-term be locked in to one viewer. The goal here is not to lock people in or organizations in. The goal is to free organizations up. You're seeing we're all about Fire, and Fire is all about APIs, and that means a whole new level of integration that becomes possible versus just having to log into our tool. We think it's going to change the game. Instead of logging into a web browser solution or, another module, we really are building the mechanism to begin to get people on their own Fire journey. Yes, you can use our viewer too, or you can work with us over the next year, 2 or 3, to figure out what you want your viewers to be like. Maybe you're already using others on top of your EHR or other environments, and maybe you can integrate with us. This is one of the most powerful things that Fire allows us to do. It's designed to support competitive advantage. Next slide. So we've been doing this migration in phases. And what we're really trying to do is to future-proof our platform. This means that as technology evolves, our participants and public can be confident that they'll continue to benefit from cutting-edge solutions without disruptions. MiHIN has been supporting the 21st Century Cures Act compliance for some of our health plans. Next slide, please. And really setting up a mechanism that helps health plans take all of their clinical information. And by the way, health plans have an insane amount of clinical information. All of their claims, all of their basic provider information, the benefits information. And we're working with them. We've been working with them to kind of package those up and expose those as a FHIR API, which is what the 21st Century Cures Act requires of these plans. That allows a Smart on FHIR app to essentially authenticate those APIs and pull down all the information at an individual patient level. Next slide. Payer-to-payer exchange is coming up quickly. There are prior authorizations and other things coming into this space. The ITP is built for these kinds of regulations, all using FHIR. And is going to play a major role in this next generation space. MiHIN has worked with FHIR Access for these health plans to get them so that consumers can enable a next generation of use cases, like electronic consent. We are looking to empower researchers, healthcare providers, public health authorities to access and export vast amounts of patient information at once without special effort. Unlike the standard FHIR APIs, which primarily focus on exchanging individual patient records, a bulk data export capacity allows for extracting extensive data with just one request. So instead of creating countless queries for retrieving patient records one by one, organizations will be able to do it with a single detailed export, and by specifying necessary FHIR data types and applying filters. Our technical migration is not just about keeping up with the times. It's about providing our participants with an even better, more secure, and efficient experience. It would be a waste to modernize when all we do is replicate the past and then start over. So if you do not see more changes and more evolution from MiHIN, we will not be pursuing our mission. I want to go back and dig into some of these slides with you, so that I can make sure to respond directly, hopefully with my colleagues, to your specific questions and concerns about our migration. I am officially opening the floor to dig in. Does anybody have any specific questions? Does anybody want to go back and look at any specific slides? How can we support this time with you? Can anybody, are people allowed to unmute? Is anybody?
They sure are. It looks like Damien has their hand up.
Oh, Damien.
Hi, this is Damian Kiska. I'm from Round Rock, Texas, and I work for Roche Information Solutions.
Hi.
And hi, I'm a big fan of MiHIN, by the way.
That's so nice.
Um,
Can we get that in writing?
if you'd like it, you sure can. One of the bulk data export, to me, is a very challenging thing. And I'm wondering if there's any sense as that capability comes online about permissions, about um, the capability to say that I have the rights and I have the ability to protect the data that I'm asking for in bulk. And could that be across organizations, for example? Could someone ask for all of the information about, let's say, Southeast Michigan hospitals? Or is it really basically an organization by organization can actually get their own data from bulk data export?
Damien, and anybody who's here with me, we have, who's our acres? So I don't know if you came to our last bits and bytes, but we sort of dove into what what MiHIN calls the active care relationship service. I don't know how familiar you are, but Kaylee, let's go back to the timeline because I want to show how long we've been working on this. And I want to thank Damien for setting us up because I did not pay. Did I pay you, Damien? I did not pay you, but I want to tell you
So
that
stipulated.
we've been working for a decade on what we call our active care relationship service. And the active care relationship service, we believe, is what what you will need, what organizations and individuals and entities will need to manage what data is legally available for you to query in bulk. The service will act and does act cross organizationally. So instead of setting up your own registries or your own ways of tracking the ecosystem, MiHIN has been doing this for a decade and plans to help with these bulk extracts, with organizations being able to say exactly what they're looking for via FHIR resource and to establish the domains and the criteria, and then match against our active care relationship service to say, here's what you are legally allowed to see.
You've had that set up for quite some time then. That's great.
And we continue to work on it, continue to update it, continue to evolve it. But that was the purpose. Exactly like what you said you anticipated sort of like maybe having a problem with or trying to get your arms around is why MiHIN created this thing. So we think
Thank
we're
you. That's very
uniquely
helpful.
positioned to help organizations in this way.
And I'll finish with this last question. And so there's an active relationship also with the public health information network, such that if there was another COVID that came along, MiHIN would be able to perhaps provide some large scale data for what might be coming down the line.
That's exactly right.
Thank you.
Thank you.
All right, next up, it looks like Oleg had their hand up, and then there's
Oleg.
a chat as well. But let's start with Oleg, and then we can go to Megan's chat.
I appreciate you, Katie. All right. So Oleg, don't get very technical on me, please.
Good morning, Joanne. And
Good morning.
I just want to confirm that, yes, I am a big fan of MiHIN. Been working with your team for the last 8 years.
You make us so much better.
Thank you very much for hard work. But one thing that, first of all, thank you for bringing this term because I didn't know how to call it, but veracity It's one that really extremely important for physician organizations. You know, I'm working for the TPA, for the Physician Alliance.
Yes.
And for us, the big challenge with not with as much with technology. Again, we always struggling a little bit with reliability, with volume, but we definitely need significant improvements in the quality of the data. And you know this. I mean, I've been advocate of this, core patient attribution and patient accuracy of the matching for the long time. And right on your slide, I think you have the common key mentioned, but when we will finally see the result, and by the way, I think you meant patient matching, not patient patching on the slide. So,
Which slide?
the one that we're looking at on the
Oh
screen.
my God, how long has that been out there? Oleg, it's patient patching. That's what we do.
Patching.
No, yes, patient matching. Can
Yes.
someone take a note? Thank you.
So again, my comment is we definitely appreciate your data governance, your data, handling the specs and the managing for the state of Michigan. But what we are missing and what we like to see, it's a better quality assurance processes. And you need to collaborate with the actual providers, with the practices, with the PO. We need data transparency. We need to make sure that the data that you sharing with us is reliable and trustworthy. This is our biggest kind of ask. And I understand it's a process. It's not something it could happen overnight in a big data world, but we like to work together and we're offering our help. And again, we're establishing these processes, but we make sure that you investing heavily in a data assurance process, in a data cleansing, in a normalization, and all this good stuff that will give our data the highest quality and will give us, this confidence in this new platform that you're building. So this is my comment regarding your efforts. Thank you very much.
Oleg,
Julian,
yes.
can I jump in here? Sorry.
Yeah, I just wanted to also, so first of all, hi, Kate. Thanks for being here.
Hello.
Oleg, you know that like we're taking you up. We're doing everything we can to integrate you into everything that we do. I did want to point out there were some updates that we are working on as it relates to the common key. I put a link to those in the chat. It's probably higher level, Oleg, than what you're talking about, but I did want to make sure to push people's attention to it. Kate, talk to Oleg.
Thanks, Joanne. Hey, Oleg, it's been quite some time since I've talked to you. This is Katie Goulette. It's nice to see you on here. Specifically with respect to Common Key, we've kind of taken a step back and really started to look at very explicitly not just what it does today within the state of Michigan, right? And looking at the patient matching and understanding, how we do deletes and retires and, kind of all those intricacies. But what we've done is we are really taking a step back and looking at how do we want this to work? What are the best practices with PICS and PDQ, and how do we make sure that Common Key actually aligns with that explicitly? As we're doing that, we are, I will openly tell you, we are road mapping out from a product strategy perspective what this will look like, but we're being very methodical about how we're doing that. We are walking through each of the situations in kind of a nuanced fashion. If you have, let's say, patients that are multiples, if you have patients that have a suffix at the end of their name, if you have a misspelling, or, if you have a registration error, et cetera, we are really taking a very granular look at how each of these things not only work today, but how we want them to work in the future. And so when I say that, I don't want to give you the interpretation that we're going to have a new answer for you tomorrow on this, okay? But I do want to tell you that we hear you, we hear others bringing this forward, and we very much understand how impactful and important our EMPI is, at this level, because we are so heavily reliant on it for everything that we do. So please know that we hear you. we are going to take you up on your offer, to Joanne's point. And we will have more to share in the coming months. I don't have a specific timeline for you, but I don't want you to think that we are just ignoring this. It is something that I actually have my team looking at very closely right now.
Thank you, Katie. And I know about your efforts because I actually had an interaction with Matt Engelhardt, and he offered the same opportunity to participate in this new MPI production that you and the development that you're doing. And I also really enjoy working with Megan. Lately, we were meeting quite often with Megan, and I know exactly what you're talking about your efforts. But again, as of today, and I have this in writing from one of your experts, that the matching, the accuracy of the matching in average, it's about 80%. This is not acceptable. When we're talking about the patients, we're talking about the clinical information and taking care of the patients. 80% accuracy of the patient matching is not acceptable. So we definitely need to work together on this.
Completely agree. You know, like and Matt is on my team, just in full transparency, and he is definitely the SME, 100%. What I will say on that is we agree with you, right? We want to be more accurate. We want to understand explicitly, you know, some of the other nuanced situations that we might not have thought of as we look to make development changes here. That also being said, right, I think from my perspective, I would tell you we want to be at least 95 to or 98% confident statistically in everything that we're pushing out. We understand that there's certainly going to be, you know, a level of variance, right? We can't get it right 100% of the time as much as we would like to. But I think the other piece of this is, to your point, Oleg, is how do we partner with you? How do we partner with other organizations who are heavily involved, you know, around the state and really at large to say, you know, how do we look at those specific pieces that we can't quite get right from a technological perspective on the matches? And how do we develop processes to make sure they are right? Because we certainly don't want to have any patient problems or safety issues come up. So
I will
anyways.
also say, Oleg, that like the matching rate is different for gaps in care. And so I wouldn't put an 80% on all of our data flows because that's not accurate. When you're looking at how we work with gaps in care, specifically through our PPQC group, it's different and it's built different. And the reason why we are going through this migration is to make sure that we understand why things were built differently and if that's working.
All right, there was Joanne, you're on mute, and if you were trying to talk, but there is a question in the chat from Megan all the way at the top. Can you elaborate on 1, the cost for the customers, 2, timeline for phase 1, 2, and 3 with, will the longitudinal record viewer be available for 1/24?
Yeah, let's go to those phases if we can. It's like, I don't know, it's, keep going, keep going, keep going, keep going. All right, yeah, let's go to those phases. Back. Oh, yeah. Okay, so cost for customers. The cost for customers for going forward is actually for, I mean, it's not changing in the near future. And we have been able to bring down the cost of some of our tools. I do think it's important to mention that we don't charge all of our participants. And we work to make sure that those that need access to the data can get access to this data in whatever way they can. So the cost for the customers is not changing, except for the price of a user on our tool, My Gateway, has actually gone down. The timeline. So the timeline is, I think anybody who's been involved with a migration will note that, you know, it runs the risk of becoming a longer and tougher experience than you had imagined. So the timelines. The phase one, we are still not out of phase one. We moved all of the data feeds that we're sending to our legacy environment. We moved all of those to send to our new environment and then back out as they always have. And so we've migrated all of those data feeds, except for the ones that needed to be cleaned up. Except for the ones that needed to be cleaned up, that needed to separate their feeds or combine their feeds. And so we are not finished yet with phase one. We are deeply into phase two, which is getting all of the data from those source systems mapped to our FHIR clinical data repository. This is major work, and I mean continues by the minute. And phase one and phase two are directly impact our phase three. So the first thing really that clients are going to see that's different is this new viewer that's replacing an older longitudinal record viewer. And this new viewer needs to be able to pull from that clinical data repository. And we need to be able to get all of the data validated and mapped to that clinical data repository, which means that we need all of the data to come in the ways that we need it to come in. So it's all incredibly dependent. And I will say that phase three, where we will be retiring the new longitudinal record and providing a new FHIR, Smart on FHIR clinical viewer, is pushing us past deadlines. We are committed to making sure that we don't leave our clients without all the functionality that they've had. So we are not going to move to a new longitudinal record until it's ready. So will the longitudinal record viewer be available on 4/1/24 is, I think, not really the question. The question is, will our new longitudinal record be ready before we retire the old one? And the answer is yes. We will not retire the old longitudinal record without making sure that you have a new one. Right now we are looking at, we're trying very hard for 4/1/2024, but those dates are pushing longer every day.
All right, a few more questions coming in the chat. Looks like Chris Gray is saying, Chris Gray is from Oakland Integrated Health Network. We are participating in ADTs with our EMR, which is PCE. Are we currently using the new ITP, or still the feeds are coming from your legacy system?
We are not currently live on ITP. So everything that you are experiencing is the same as what it has been.
All right, and then Amy Robertson is asking, when did the new pricing for customers begin?
The new pricing for customers begins for each customer based on their contracts. So if you were up for new pricing, you will be finding out about new pricing. We will not be changing your pricing until we give you something better than what you have today, and until it's time to renegotiate your contract.
And Chelsea is asking, any updates on what the new inbox will be?
For those of you who don't know, Inbox is part of our like a legacy offering. And Chelsea, there aren't updates that I can talk about today here, but we do have a plan. And you should know, again, that you will not have anything taken away from you until the replacement and the upgrade is available. I think there's a question. Can you specify the date range for when the longitudinal record will begin? Is there a cutoff date for the data within it? I can't specify when the longitudinal record will begin. I can specify that the longitudinal record will not end and therefore will not begin. It will be a migration, and you'll be taken off of the old and put onto the new. Is there a cutoff date for the data within it? We are moving data over to Smile, to our clinical data repository, slowly and methodically. And so all of the data that exists historically will not be in there day one. We have committed to making sure that you can access CCDAs going back to, I think, 2021. And the CCDAs that exist between that date and today can have encounters and information in them going back 6, 7, 8, 9 years. We don't anticipate that you are going to be left without the data you need. Do we have any more questions? I'd like to move forward. Kaylee, can we just go back to the let's go back to, keep going. Let's go back to the the 21st Century Cures Act.
Joanne, you did get another question.
Oh,
Sorry to interrupt you.
Good, great, thanks. How do you onboard to the new ITP? That's a really good question, Chris, and it depends on how you participate with MiHIN. I can't impress upon you enough that we are combing through our environment. And when we comb through our environment, we find new things and new ways to work with each of these clients every day. So how you work with MiHIN today will directly impact how you onboard to the new ITP. You may not have to onboard. You may just continue receiving your data. You may have to create a new password and authentication for My Gateway. You may have to start participating in the active care relationship. So depending on how you participate today, will be how we onboard you to this new technical environment. Smile CDR will not include historical data from prior to 2021. In our first phase from day one, we don't plan to put data from prior to 2021, but the data that we are putting in there may include information and data from prior to 2021. And we are going to be waiting and paying attention to what people are seeing in their environments. So of course, we'll be testing, we'll be doing all of our quality assurance. And the data that we have is not going anywhere. It's just messy. And to get it into Smile CDR is a lot of work. And so we're moving backwards. So Hannah, if you are not finding what you need in our network, we will get you what you need. Maybe just not on day one. I wanted to also ask here if anybody in the audience has been working on your own fire technologies, your own fire viewers, your own bulk fire registries. We would love to build and to create with you as you're on this journey. If anybody here is there, we'd love to hear about it.
It's Oleg again. We started working on a provider directory, trying to to start, because it's easy. Obviously, we have only like 400 providers, but we'd like to be able to collaborate with MiHIN, because this particular use case, I don't think that it has this fire capabilities built already, but we'd like to start with maybe providers data exchange.
That's interesting, Oleg. Wait, I want to dig in, but I sort of don't want to take anybody's time. But when you say provider directory, are you talking about which providers, where, and how?
Yes, and basically just the basic information: office address, proper practice naming. Multiple. We have like a list of different issues that we discovered in terms of the NPIs and associated attributes to these providers.
Yes. So we are working on that. And I don't know how you can connect with all these people, but Fire does, there is a way to support this work. And we've been looking at it from all different angles, including OIDs, including NPIs, including location codes. So we are deep in that work and would love to share with you what we found and how we're building. I don't know if it would make sense to build separately. Certainly what you know about your people and who you think they are and where they are should match what we do.
Yeah, and I'm glad you mentioned OIDs. We're still manually pulling the Excel spreadsheet, and not everyone. We even discovered that our vendor that does ADT for us, they have a hard time to have a current OID numbers from MiHIN, the OIDs that are assigned by MiHIN.
The MiHIN assigned OIDs. We have like a OID mapping, an OID mapping project that has been underway for about 2 years. I'm happy to give you more information about that and see how what we've done can help you and save you time. there was this question, we had a niche Chopra come and visit with our hospitals maybe a year ago, year and a half ago. And there was this question about OIDs going away. And you know, Tim didn't think that that was going to be happening in the near future, but we started the work then. And so we should ask Oleg about our OID mapping project.
Okay, thank you.
Looks like 2 more questions have come in. So Jill was asking, what will existing users of My Gateway who access Viper have to do after cutover to new ITP? Is there a date when onboarding new users to My Gateway will be paused?
So current users of My Gateway will have to reset their password and go through and like a re-authentication. And then essentially what they will be will give you a new URL, and you will be connected to the new My Gateway that will house the new longitudinal record. The new oh, and by the way, this is a plug. On the 29th, we're doing a Bits and Bytes on My Gateway. And that will include some slides about our new longitudinal record, our new FHIR clinical viewer. But basically, they'll be going to a different website and reaffirming their password and authentication. Then they will click on the button that used to say Viper, which will say longitudinal record, and they will see a new longitudinal record that will act in the same way. The data will be aggregated. You'll see your allergies. You'll see all of those things that make a longitudinal record what it's supposed to be, in the same place that Viper was. Target date for Viper replacement. Target date for Viper replacement is around April 1st, but I'm anticipating that there will be another push. We are committed to giving you and your users everything they need to be able to understand this new system. But we don't anticipate that it's going to be much different from what they understand and how to use the current longitudinal record. It's just going to have more robust data, right? Because it's not pulling from one system. It is pulling from an integrated system. So we expect that you will see a wider berth of data. And you'll move through, maybe the allergies won't be on the left hand of the page when they were on the right. But we have been going and doing our due diligence to make sure that every single functionality is the same, if not better, than what you had.
All right, and then one more question. It says, I manually upload acres/APS files. Are these file specs going to change? Is the SFTP that I uploaded these files to after the platform upgrade going to change?
After the SFTP for your flat files for acres, I don't know if there's a set answer. The acres spec is not expected to change, and the way that you upload is not expected to change. You may have to re-up, set a new password, something like that, but I don't think it will be different than what you do today if you are on the automated SFTP process. Who asked that question? Sorry, I didn't see. Kate, do you know who? Oh,
No, it says anonymous
okay.
attendee, so I'm not sure.
Anonymous, we need to know, write me an email and tell me who you are, and I'll tell you if you are on a legacy acres file submission, it will change. If you are on an automated file submission, we don't expect it to change very much.
And I just put Joanne's email in the chat, so that way you are able to
Yeah.
email her if you'd like.
I want to encourage everyone here also to please sign up for our newsletters to make sure that you're getting our emails. I regularly, I'll send out these slides. Phil, I see you're here. I send out the slides and the recordings of these. We work really hard on our newsletters. We also want to make sure that you are on any of our downtime and incident lists. So if you're not hearing from MiHIN, you should be. And it might mean that you are not, that you're not getting what we're throwing out there. Let's end on a positive note. So Kaylee, can you put it to the slide where change is constant? Migrations are not easy. And we are really just committed to getting through this and coming out on the other side so much better. And we're better because of you. So thanks for taking your time. Thank you for participating in our nonprofit health information exchange. We believe that it's transforming healthcare and public health and care delivery in general for the better. Thanks.